Hi, my name is Sharon Greene. I'm the Director of the Data Analysis Unit at the Bureau of Communicable Disease at the New York City Department of Health and Mental Hygiene. The purpose of our study was to describe disparities in disease incidence in New York City across area-based poverty levels. We did this by systematically analyzing a large set of selected reportable communicable diseases. We're based at the Bureau of Communicable Disease at the New York City Department of Health and Mental Hygiene, and New York City has very pronounced income inequality. We do know that socioeconomic position is associated with different morbidity and mortality outcomes, but before this study, we hadn't completely characterized the extent to which these disparities exist in New York City for many communicable diseases. We defined area-based poverty as the percent of residents in census tracts with incomes below the federal poverty level, according to the American Community Survey. So for a given report of a communicable disease, we took the patient's address at time of report and geocoded it to a census tract. We then linked that with data from the American Community Survey on poverty level, and then grouped our cases into 4 levels, ranging from low poverty, defined as less than 10% of residents below the federal poverty level, to very high poverty, defined as at least 30% of the residents in the census tract living below the federal poverty level. We don't routinely ascertain household income for individual patients with a reportable disease, but area-based poverty can be used as a proxy for individual level socioeconomic position. Area-based poverty can reflect a mix of individual level and area-based socioeconomic effects, and can be used to define populations at increased risk for disease and for describing disparities. As for the list of diseases that we analyzed, there is a list of conditions that are required by law under the New York City Health Code to be reported to the Health Department, and the Bureau of Communicable Disease is responsible for more than 70 of those diseases. We had an 8-year study period, and that gave us adequate sample size to look at the association between disease and poverty for 41 diseases. This included a wide range of diseases. It included the hepatitis, zoonotic and vector-borne diseases, invasive bacterial diseases, diseases transmitted through fecal-oral transmission or through international travel, as well as other diseases. The one disease that was most strongly associated with residing in high-poverty neighborhoods was called rickettsial-pox. This is a disease that's transmitted to humans from mice via mites. And the finding was that residents in the highest poverty neighborhoods had 3.7 times the risk of being diagnosed with rickettsial-pox compared with residents in the lowest poverty areas. We believe this is because residents of high poverty areas are likely to have greater exposure to house mice. Another disease strongly associated with high poverty was chronic hepatitis C. This association has been previously reported. It is driven by mainly the older age groups, especially the baby boomer cohort, and it is thought to be related to injection drug use. Curative treatment is available for chronic hepatitis C, so today we're talking about diseases that are amenable to public health intervention, and we can do some work to reduce these disparities. Another disease associated with high poverty is chronic hepatitis B, and in New York City, this is largely driven by immigration patterns from China. Also, malaria was very associated with high poverty in New York City. All of the cases during the study period were travel-related. The majority of patients were infected while traveling to visit friends and relatives or before recent immigration to New York City. This association with high poverty does likely reflect immigration patterns, and patients in these areas may be less likely to access pre-travel health care, partly due to costs perhaps, but partly also due to the belief that prophylaxis isn't needed. So we should continue to promote anti-malarial prophylaxis among at-risk travelers residing in these high poverty neighborhoods. In total, there were 18 diseases that were significantly associated with residing in high poverty areas. On the other hand, there are also 11 diseases that were significantly associated with residing in low poverty areas. These included the tick-borne diseases, so Lyme disease, babesiosis, and others. This likely reflects a population who has adequate resources to travel to areas outside of New York City where the infected vectors are prevalent. Also, diseases associated with low poverty included Shiga toxin-producing E. coli, hemolytic uremic syndrome, vibriosis. These might reflect differential exposure to contaminated foods across the different poverty levels, different food preferences, perhaps different restaurant dining patterns. More study is needed. We believe these findings should be useful as serving as a baseline for monitoring disparities over time and perhaps across jurisdictions. And as we see this as a starting point for additional disease-specific analyses to clarify the subgroups at highest risk and really identify the reasons for the observed associations. We want to use these findings to target outreach, educational efforts, and other prevention measures to support programs that will minimize these disparities. If there are folks in other health departments who might be interested in replicating this analysis for their own jurisdiction, I would offer some suggestions. One would be to be sure to engage and solicit input from subject matter experts and other local stakeholders. I would also recommend visiting the website of the Public Health Disparities Geocoding Project. That website was prepared by the Harvard School of Public Health. It's a wonderful resource. It has very detailed analytic methods and some sample SAS code and really everything you need to try to replicate this analysis using your own data. And also, I would recommend linking with the Health Disparities Subcommittee of the Council of State and Territorial Epidemiologists. This is a community of practitioners who are working to increase the public health data that are reported by socioeconomic position and ultimately monitor disparities and work towards minimizing those health disparities. Thank you.